Welcome to the Structured Operative Obstetrics course on surgical detail for cesarean sections. This presentation aims to educate healthcare professionals about the provision of cesarean section. It will cover the essential steps involved in performing a cesarean delivery, highlight the indications for the procedure, and discuss the necessary preoperative and postoperative care. A cesarean section is a surgical procedure used to deliver a baby through incisions in the mother's abdomen and uterus. Providers use it when they believe it's safer for the birth parent, the baby, or both. A cesarean section can be performed in an emergency or as an elective case. If it is the first cesarean section, it can be labeled as primary, or it can be repeated if there has been a previous procedure. There are several indications for cesarean section. Some will be recommended to have a cesarean section without ever laboring, as is the case for patients with a transverse fetal lie, or if they have placenta or vasa previa. Women with medical conditions, like heart problems, where it would be unsafe for them to push due to stress on the heart. Sometimes, cesarean birth becomes indicated intrapartum, during labor, for example, when there is a cord prolapse at the time of rupture of membranes if the labor is not progressing or if there are signs of fetal distress. Cesarean birth may also be recommended if there is concern about fetal growth or severe preeclampsia, when there is not enough time to induce labor. Patients may also be recommended to have a cesarean birth if they have previously had surgery on their uterus, including abdominal myomectomy or previous cesarean birth. A thorough assessment of the mother's health, including medical history and current conditions, is essential before surgery. The surgical team prepares the operating room with the necessary instruments and ensures all team members are ready. Informed consent involves discussing the procedure, its risks, benefits, and alternative options with the patient. Anesthesia may include regional, epidural or spinal, or general anesthesia based on patient needs and medical recommendations. The usual prophylactic antibiotic is cefazolin, which is given based on weight. This significantly reduces the risk of infection. Let's discuss the key surgical steps involved in a Caesarean section. Each step is crucial for ensuring the safety and success of the procedure. The surgical procedure begins with an incision in the abdominal wall. This step is critical for visualizing and accessing internal organs. The initial skin incision can be made suprapubic transverse or midline vertical. A vertical midline incision is considered to provide faster access to the abdominal cavity, and it disrupts fewer tissue layers and vessels, leading to recommendations as the preferred method to perform an emergency cesarean. However, a transverse skin incision is often the most used and is preferable in most cases due to improved wound healing and patient toleration. The phalansteal incision is located about 2 fingerbreadths above the pubic bone. The skin incision should be 12 to 15 centimeters long and it is best to cut through the dermis and epidermis with a single sweep of the scalpel. The subcutaneous layer, located just beneath the skin, can be dissected using blunt or sharp techniques. However, it is essential to be careful because blood vessels are present throughout this layer. To minimize blood loss, surgeons should limit sharp dissection to the midline until reaching the fascia. Once the fascia is accessed, switch to blunt dissection when working laterally. This approach helps reduces the risk of excessive bleeding. Techniques for opening the fascia during cesarean section differ based on the primary incision type. This image shows how you would open the fascia when the incision is transverse. Make a small incision using a scalpel near the midline of the abdomen. You should be able to see the rectus muscles on either side of the linea alba, which confirms where the midline is. Extend this incision laterally using heavy curved Mayo scissors. To avoid lateral structures and bleeding, you should curve your incision upwards at the lateral edges. If the patient has had no prior abdominal surgical procedures, you may choose to bluntly extend this fascial incision. This method involves gently spreading the layers of fascia apart with your fingers, which can provide faster access and help minimize trauma and bleeding. Sharp dissection may be required for a patient with adhesions due to previous surgery. Once the fascia is open, the muscles naturally split in the midline. You may need to separate them off the fascia if you are entering with sharp dissection and not blunt. The peritoneum can be entered bluntly, or it can be grasped with two hemostats and cut between them to create an opening. Ensure there is no bowel adhered to the peritoneum prior to cutting. It can be stretched bluntly, and additional room can be made with scissors or electrocautery as necessary. Next step involves opening the peritoneum overlying the bladder and lower uterine segment. This step is essential for adequate exposure to the lower uterine segment. Start by identifying the vesico-uterine fold of the peritoneum, which lies between the bladder and peritoneum. Proper visualization of this area is vital for making an accurate incision. Grasp the peritoneum to lift it off the uterus and find a thin plane. Make a small incision here. This initial cut should be done cautiously to avoid penetrating too deeply and potentially injuring underlying structures such as the bladder or bowel. Once made, medicine-bound scissors can be used to extend this incision laterally on both sides, and blunt dissection can be used to separate the bladder peritoneum off the lower uterine segment. While opening the bladder peritoneum is a routine part of cesarean sections, surgeons might encounter several uncommon scenarios that might complicate the operation. Understanding these challenges is essential for minimizing complications and ensuring patient safety. The round ligaments play a significant role in supporting the uterus. During the procedure, these ligaments may become inadvertently manipulated or injured when accessing the bladder peritoneum. This may complicate the surgical field, potentially obscuring the visibility of critical structures. The rotation of the uterus can pose challenges during surgery. If the uterus is not in its expected position, it may be rotated or tilted due to factors such as prior surgeries or anatomical variations. This malpositioning can make it more difficult to identify landmarks and can increase the risk of bladder injury when attempting to dissect the peritoneum. Surgeons must be vigilant in assessing uterine position and adapting their approach accordingly. Scarring from previous cesarean sections is a common issue that can complicate subsequent surgeries. Adhesions from prior procedures can obscure normal anatomical planes, making it challenging to open the bladder peritoneum safely. In general, by being aware of these challenges and employing careful surgical techniques, we can minimize risks and improve outcomes for our patients. Opening the uterus is a pivotal moment in the cesarean section, as it allows access to the fetus. The incision is typically made in the lower segment of the uterus, which is less vascularized compared to other areas, thus reducing the risk of excessive bleeding. Before making any incisions, it is crucial to check the position of the uterus and ensure that you are oriented correctly in the midline. Accurate identification of the midline ensures that the incision is made symmetrically and reduces the risk of damaging adjacent organs, such as the bladder, or having too large of an extension of the uterine incision. Factors such as uterine thickness, previous surgical history, and fetal position can influence where the incision is placed. The goal is to ensure optimal access while minimizing complications. Once the appropriate location for the incision has been determined, make an incision just above where the bladder has been reflected downwards. This positioning helps again to avoid bladder injury. After making the initial incision, it is advisable to score in a curved line, resembling a smile. This technique allows for better expansion of the incision as you enter and helps direct tearing away from the uterine arteries, which are lateral. The hysterotomy can then be extended laterally or in a cephalad-caudad direction. Usually we avoid lateral extensions, to decrease the risk of the hysterotomy tearing through the lateral uterine arteries. Delivering the fetus. If the amniotic membranes are still intact at the time of uterine incision, the first step is to rupture the membranes. This can be done using a sterile instrument, scissors, or toothed forceps. After rupturing the membranes, the surgeon should reach into the uterus with the dominant hand to locate the fetal head. The goal is to flex the head by gently maneuvering it into a more favorable position for delivery. In some cases, it may be necessary to disimpact the head if it is lodged, as would be the case with arrested labor, or not in an optimal position for delivery. This step involves carefully maneuvering the fetus to free its head from any obstruction or malpositioning within the uterine cavity. Once the fetal head is positioned correctly, it is crucial to deliver carefully and gently. The delivery should be performed with controlled movements to minimize stress on both the mother and baby. The surgeon should support the fetal body as it emerges through the uterine incision while ensuring that no excessive force is applied. Throughout this process, an assistant can provide fundal pressure to aid in delivery. Fundal pressure involves applying gentle pressure to the top of the uterus, the fundus, to help guide and facilitate the descent of the fetus through the incision. This collaborative effort can enhance delivery efficiency and safety. After the fetus has been delivered, it is standard practice to administer oxytocin intravenously. Oxytocin is a hormone that plays a crucial role in stimulating uterine contractions. Administering oxytocin helps the uterus contract effectively, which is vital for expelling the placenta and reducing the risk of postpartum hemorrhage. Some centers may have access to a stronger, synthetic version called carbetocin. Once the baby is fully delivered, the next step is to clamp and cut the umbilical cord. The cord is clamped in two places. The segment between the two clamps is then cut with sterile scissors. This step is usually done after a delay of 30 to 60 seconds if the fetus is vigorous and there is no maternal concern. Delivering the placenta during a cesarean section involves several critical steps. Performing fundal massage, applying controlled cord traction, facilitating spontaneous delivery of the placenta, and carefully examining both the uterus and placenta post-delivery. There is less risk of infection if you allow the placenta to deliver on its own with the above interventions. Alternatively, if you need to deliver the placenta quickly, you could remove it manually by reaching into the uterine cavity and separating it from the uterine wall. Once delivered, it is essential to examine both the uterus and placenta thoroughly. The surgeon should check for any tears or retained placental tissue within the uterine cavity. Ensuring that no placental fragments remain is critical to preventing postpartum complications. Once the placenta has been removed, the next step is to close the uterus. The first decision to be made is whether you will exteriorize the uterus. Exteriorization involves bringing the uterus outside of the abdominal cavity for closure. In contrast, intraperitoneal repair involves closing the uterus while it remains inside the abdominal cavity. The choice between these techniques should be guided by individual patient circumstances, surgeon preference, and clinical judgment. Removing the uterus from the intraperitoneal cavity allows for better visualization and may be useful if there is a large extension of the hysterotomy incision. However, there is a higher risk of infection. Leaving the uterus in the abdominal cavity may be necessary too if there are large fibroids making exteriorization difficult. The first step in closing the uterus involves using green armitage forceps to clamp the edges of the uterine incision. This is where the hysterotomy tends to bleed the most, so by clamping these areas you will decrease blood loss. These forceps are specifically designed to grasp and secure tissue effectively, providing a firm grip on the uterine edges. Clamping helps to stabilize the tissue, allowing for better visualization of the uterine margins and ensuring that any bleeding can be controlled as you proceed with closure. After clamping, it is essential to assess the corners of the incision for any extensions or irregularities. This step is crucial to ensure that there are no unexpected tears or extensions that could complicate closure. The next step involves using a running suture technique with Vicryl 1 or an equivalent suture material. The sutures should be placed approximately 1 cm apart, ensuring that they penetrate through all layers of the myometrium. Throughout the suturing process, it is critical to continuously assess and ensure hemostasis as you go along. This involves checking for any bleeding from vessels as they are encountered and taking appropriate measures to control it. This is what a running suture on the hysterotomy would look like. After completing the first layer, it is essential to assess for any bleeding and ensure that hemostasis has been achieved. This minimizes the risk of hematoma formation or infection. Uterine closure after a cesarean section can be performed using either a single layer or double layer technique. The double layer closure method involves closing the uterine incision in two distinct layers, which is traditionally considered to provide better support and healing by ensuring that all layers of the uterus are properly approximated. Research indicates that double-layer closure results in thicker residual myometrial thickness and may reduce complications associated with uterine scarring in future pregnancies. Conducting a thorough assessment before closing the abdomen during a cesarean section is vital. Ensure that there are no actively bleeding vessels from the hysterotomy, especially at the corners. Then, check the bladder flap. You should also assess ovaries and tubes for integrity and any pathology. A surgical count of instruments and sponges is usually done as well to ensure they are all accounted for. This step is variable and depends on the surgeon. Certainly, it is faster to avoid this step. However, anecdotally, surgeons have found that there are fewer adhesions of the uterus and bladder to the muscle of the abdominal wall when the peritoneum is closed. There is little benefit in closing the bladder peritoneum. Once hemostasis of the rectus muscles, peritoneum, and uterus are confirmed, we can move on to the next step, which is closing the fascia. The fascia is the main strength layer of the abdomen and should be closed with a strong delayed absorbable strong suture, such as vicryl, in a continuous manner not locking. Aim for the sutures to be 1 cm apart, and 1 cm into the tissue on either side. You want to restore integrity to this layer, without causing necrosis. The subcutaneous layer, which consists of fatty tissue beneath the skin, plays a significant role in wound healing and overall recovery. Adequate closure of this layer can help reduce complications such as hematomas, seromas, and wound dehiscence. If the subcutaneous fat is less than 2 cm, studies suggest that closure may not significantly impact outcomes, so it is usually only re-approximated if it is thicker than this. This layer can be closed with interrupted sutures. Proper skin closure is essential for minimizing complications such as infection, wound dehiscence, and ensuring optimal cosmetic outcomes for the patient. The skin can be closed with staples or sutures. If using sutures, the subcuticular technique involves placing a continuous suture just beneath the skin layer. It provides excellent cosmetic results and reduces the risk of scarring. Absorbable sutures are usually preferred since they do not need to be removed. Then, confirm again that there is good hemostasis and apply a sterile dressing. After closing the uterus during a cesarean section, it is essential to evacuate any clots using gentle fundal pressure. Document all relevant details in an operative note along with post-operative orders, and communicate effectively with the patient and their family about how the procedure went. While cesarean sections can prevent complications, they also carry risks such as infection, longer recovery time, and blood loss. After surgery, patients are monitored closely for vital signs, bleeding, and pain management to ensure safety and recovery. Pain relief strategies include medications and non-pharmacological methods to enhance comfort during the recovery phase. Planning for immediate skin-to-skin contact post-cesarean can positively influence bonding between mother and child. Proper wound care prevents infections and promotes healing. Patients should be educated on signs of infection and proper hygiene practices. Recovery involves gradual return to normal activities, with follow-up appointments to monitor healing and address any concerns. In summary, cesarean section is a life-saving surgical procedure but is also a major abdominal surgery that involves incisions in the abdomen and uterine muscle to deliver baby. After delivery, the uterus and abdomen are brought back together with suture and hemostasis is ensured at every step. Healing from a cesarean section requires good care of the incision to prevent infection, minimal strenuous activity to decrease risk of wound or fascial dehiscence, and good pain control.